So acute pericarditis is our next kind of circulatory kind of problem that we want to talk about, primarily because it affects the heart. So acute meaning not long-term, pericarditis, peri meaning the area around, card, the heart, itis, inflammation. Fancy way of saying the heart bag is all swole up. That's the big problem here. So this is kind of a good summary of things that we're going to be talking about, but this is what we're talking about. This sac, or the pericardial sac, is where that inflammation occurs for our patients. So patho, the reason people get this, lots of different reasons. It can be all sorts of things. It can be idiopathic, meaning we're all idiots because we can't figure out the pathology. It's pretty sure that's direct Greek translation there. But we don't know the reason, is what idiopathic means. Infective, so a bacterial, viral, fungal source. Acute MI, myocardial infarction, so a heart attack can cause that inflammation in the pericardial sac. Cancer, so an invading neoplasm. Neoplasm is just a fancy way of saying tumor. Can cause the irritation of the pericardium or a tumor. Also trauma, so our blunt chest injuries can cause acute pericarditis as well. Etiology, like we said, inflammation of the pericardial sac, the bag around the heart, resulting in a collection of fluid. Sometimes there can also be a collection of fluid between the bag and the heart, which is bad. So increased pressure on the heart equals decreased cardiac output. Kind of like we learned about with effusions in the lung. If fluid accumulates in the sac doesn't stretch. So what it does is compresses what's inside of it. So the more pressure gets placed on the heart, the less able it is to relax and contract the muscle activity. So it tends to say more compressed, meaning there's less cardiac output that the patient is able to produce. So big problems can lead to, the words are hard. This can cause big problems for our patient if they start to have that fluid accumulation. Symptoms that we have for patients with acute pericarditis, weak pulses are one of them. So because that decreased cardiac output, our pulses, so our radial pulses, our pedal pulses, can be very diminished. So we do want to look out for that. Distant heart sounds. I don't know why this didn't show up in red, but consider this red. Distant heart sound. So when you listen to their heart, because of that inflammation, there's a density around the heart. It's going to sound like their heart sounds are much more faint or further away than you would anticipate. So when you listen, you're used to hearing that boom, 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 like you guys heard on each other when you were doing health assessment. For patients with acute pericarditis, it'll be like boom, 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 boom. They're going to sound very distant, very far away. Friction rub is also one of the hallmark symptoms of acute pericarditis without fluid collection. So a friction rub occurs when that normal small amount of fluid that lubricates the heart against the bag that it's in, it's not able to lubricate as well because the inflammation has caused pressure. So now the heart bag is sitting directly on the muscle tissue because it's all swole up. Friction rubs are a funny thing. Here's what they sound like. It's like a rubber band rubbing together. So I'll see if I can make this sound for you. I've heard a friction rub once and it was like, you don't even hear heart sounds anymore. There's no S1, S2. All it is this rub. So yeah. There it goes. Yeah, so it's like rubber band sounding. It's really weird. Sorry, I got kind of into that. That was creepy. Other thing is JVD. So JVD stands for jugular vein distension. Because these patients are not able to have effective cardiac output, their jugular veins may inflame. So remember from your head to toe exam, when you sit the head of their bed up, their jugular veins are going to stay distended. They're not going to drain when they go from laying supine to Fowler. And shortness of breath, again, from that poor cardiac output, it's going to look a lot like our congestive heart failure type of presentation. So these are all the things we need to assess with our patient. Heart sounds, big deal. We got to do a focused cardiac exam. Pulses, So peripheral circulation, a big thing. Jugular vein, peripheral pulses, all that stuff, huge, huge deal. And then respiratory, if we're starting to tick some of these boxes, we definitely want to be very careful about a lung exam as well. So for medical diagnosis, the way that our doctors are going to diagnose a patient with acute pericarditis, first screening, do they have a history of illness? Things like recent trauma, especially blunt trauma to the chest. So cardiac tamponade is one of those ones that is a medical emergency. So this is that abnormal collection of fluid in the sac around the heart that causes pressure on the heart so it can't beat as effectively. I don't have a picture of cardiac tamponade, but the way I remember this is usually what happens as a result of trauma is that cardiac sac or the pericardium fills with blood. So if you need to soak up a lot of blood, you're going to cut these patients open, and you guys can kind of see where that's going. If you need to soak up a lot of blood, you need one of these, so a cardiac tamponade. It's kind of a gross way to remember that, but I'm an old ER nurse. I'm just kind of gross. Other reasons, idiopathic reasons, so a pericardial effusion. So kind of like our pulmonary effusions, our respiratory system effusions, if they just develop as a result of a disease process, we don't know why they develop. We have to figure out what disease process they have in order to determine what the cause of their effusion may be. It's not a normal place that patients develop an excess of fluid volume. The main reason that happens is from blood collection from trauma. For definitive diagnosis, again, echocardiograms. We're going to do that ultrasound. We want to visualize the inflammation of the pericardium, of the sac around the heart. Here's what that looks like. So that white, that's the inflamed pericardium. Normally it should be so thin, it's almost like just a pencil line around the outside of the heart. But this person has some pretty severe acute pericarditis. There is not cardiac tamponade going on. What you would see with cardiac tamponade is you would see the outside of the heart, then you'd see like a uniform kind of band, and then you'd see the pericardium. So it'd look almost like an Oreo cookie in here. You know, you have 2 layers and then stuff in the middle, is what you would see with a cardiac tamponade type presentation. This can be done TTE or TEE. Either type of echo can be done, depends what the physician, how detailed an image the physician wants to get on that patient. And then this is where we can do, if they do have that fluid collection around the heart, we need to drain it. So these patients may get a pericardiocentesis. Pericardio, peri, around, heart, centesis. Stick a needle in it, get the fluid out. So stick a needle, get the fluid out of the area around the heart. That's what we're doing. So this is like full on Pulp Fiction style, like whack, right in the chest, except not as much like whack. So they're gonna stick a needle, usually kind of below the sternum, like right kind of down here, up into the heart. They're aiming for the apex of the heart, or kind of down in that area, until they can draw off whatever fluid, whether it's effusion fluid or whether it's blood, from around the area of the heart. So inside the pericardium, but not stabbing the heart. As you guys can imagine, this is a very difficult procedure to do because the heart doesn't like to sit still for very long. So it can be pretty challenging. So patients with acute pericarditis, some of our nursing diagnoses that we want to look for, so the things we're concerned about, acute pain. This can be a very, very painful thing for patients, especially around the inflammation that they may have from either trauma, those sorts of things. Altered respiratory pattern. When patients have that acute chest pain, they tend to breathe really shallow, that kind of thing, so they're not perfusing very well. Altered gas exchange can result if they've been doing this for quite a while. Activity intolerance, another big one. Impaired cardiac output if they start to have that pressure on their heart. So a lot of pretty severe cardiac complications that we need to pay attention to and look out for diagnosing in our patients. The plan for this, we need to make sure our patient stays stable. Since there's a high risk of compressing the heart, decreasing cardiac output, there is a high risk that the cardiovascular system can become unstable, meaning their blood pressure can completely crash because they don't have any cardiac output as pressure on the heart increases. Positioning can be a big deal for these patients, both in terms of facilitating cardiac output and eliminating pain. To facilitate cardiac output, usually what we want to do is lay a patient supine. Unfortunately, for patients with acute pericarditis, this can be very, very, very painful because all the weight of their sternum and their chest wall kind of lays on the heart. So it's almost like if you had an inflamed area and then you poke it. So it's not going to feel very good at all. And they're going to poke it with every heartbeat. So the things we want to do is we want to put these patients in Fowler's position, sit them up. That way we can take the pressure of the chest wall or the weight of the chest wall off of the heart. Other things we can do if that doesn't work, we can lean them over a bedside table. So you get their bedside table and you just kind of have them lean over it like this. It's almost like that posture if we're doing the centesis thing for the lungs. I just drew a blank on the name. The thoracentesis, that's the one. So get them leaning over a bedside table, that kind of thing will fully take the pressure of the chest off the heart and can help alleviate some of their pain. Medically, they want to relieve the pressure. So things they're going to do, medical management of the underlying cause. So if there's an infective reason that they have this acute pericarditis, antibiotics. Also, steroids. Steroids are one of our big anti-inflammatories. So we're going to be giving IV steroids to these patients in order to decrease the inflammation of the bag around the heart. Surgical management is really reserved for those patients that have fluid accumulation and altered cardiac output. So a pericardiocentesis, so that's the stick the needle in there and pull out the fluid kind of thing. We're going to try doing that because that's just a needle in, do your thing, needle out, patient can heal, close up, all that good stuff. If they're reaccumulating fluid, then we're in a slightly different place. They're going to get a chest tube into their pericardial space or into their pulmonary space, but what we're going to create is a surgical window, meaning they're going to cut a little window or a little square out of the pericardium and allow that bloody drainage to just drain into the kind of pulmonary space, into that not pericardial, but the same space where a pleural effusion would kind of accumulate. So we'll insert chest tubes and then collect the drainage long term through those chest tubes. So these patients may end up with a chest tube, not for respiratory reasons, but for that cardiac decompression if we create a window in their pericardium for that fluid to drain. So implementation stuff, chest pain evaluation. One of the big things we want to look out for as pressure on the heart increases, we want to make sure that it's not causing ischemia or almost a pressure injury to the cardiac muscle tissue. If they do have ischemia or tissue death to the heart muscle, that's an acute heart attack or an acute myocardial infarction. So this can cause a heart attack externally from pressure injury type stuff. So if they have pain that persists even if we change their positioning, so we try that kind of bent over the table thing, no change, then we may start working them up for an acute heart attack. Pleuritic pain. So this is pain that increases and decreases with changes in position. So if this kind of positioning works, they have a pleuritic pain. The other thing that may increase their pain is regular ventilation. Changes the body positioning, changes the pressure on the chest when they expand and contract their chest wall. So that's one of the things we want to look out for. So PQRST assessments, do our full pain assessment on these patients. Big, big deal for our implementation stuff. And then hemodynamic stability. We want to make sure that if there is pressure placed on the heart, that it is able to maintain an appropriate cardiac output so we can maintain hemodynamic stability. For evaluation, so after we do all this kind of stuff, that dude's clearly having a bad day. Yikes. If things are going good, we can relieve the pressure by the least invasive means possible, right? Because we never want to dive to doing that to people. if they have this kind of acute pericarditis, what we want to do is the least invasive method possible. So if we're not able to manage it with antibiotics, steroids, that's our least invasive. Our next most invasive is our pericardial centesis. Stick a needle in it, take the needle out, right? Our most invasive means of intervening is our pericardial window, where they're going to have full-on surgery like this, and then we're going to remove part of that pericardium, let it drain into their pleural space and drain it through a chest tube. So we need to prep patient for surgery as needed. So first we're going to try medical interventions, but every intervention after that is some type of surgical procedure, right? We're either doing a needle puncture or a full-on surgical procedure, but we do need to prep them for if this doesn't work, here's the next steps. If things go bad in our evaluation, the things we need to look out for, then they've lost cardiac output. So their blood pressure is going to drop, their heart rate's going to rise as they're starting to present with that cardiovascular collapse, and eventually they're going to have a tanking blood pressure and a tanking heart rate. These patients are going to require emergency surgery. So they're going to have that cardiac tamponade. We're going to open them up just like this, open up the pericardium, look at the heart. It's kind of that exploratory surgery, but we know where we're exploring. We're exploring the heart. We want to open it up, see what's wrong, fix the problem, and then close them back up and deal with the consequences later. But that's our acute pericarditis. Next, we're going to talk about vascular disorders around the circulatory system, not so much in the heart. So we're getting outside the heart.